Good morning, good afternoon. Welcome to today's presentation, Empowering Refugee Claimant Youth to Navigate Healthcare in Canada. Before we begin our presentation today, we would like to begin with an acknowledgement that N4 is hosted at CHIO, which is located in Ottawa, Ontario. Ottawa is built on unceded Algonquin and Anishinaabe territory. The peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. We also honor all First Nations, Inuit, Métis peoples, and their valuable past and present contributions to this land. And with today's session, we asked through our April newsletter poll whether our readers had newcomer clients that experienced issues with their interim federal health plan. From our responses, we have confirmed that newcomers do continue to experience barriers to healthcare when covered by the IFHP, which is very relatable to today's topic. My name is Colleen Drake. I am N4's Project Engagement Coordinator. I will be hosting and moderating today's presentation with my colleague and co-host, Andrew Tomeyer, Education Coordinator, who will be behind the scenes moderating the Q&A box today. I am now pleased to introduce you to today's presenter. I'm going to ask that you turn on your video as I introduce you. Welcome. Dr. Shazeen Suleman is a clinical associate professor in general pediatrics at Stanford University. She is the co-director of community engagement with the Office of Child Health Equity and a global health faculty fellow. She holds a courtesy appointment with the University of Toronto, Temerty Faculty of Medicine, and is an affiliate scientist with the MAP Center for Urban Health Solutions. Prior to joining Stanford, she developed the Compass Clinic, a trauma-informed multidisciplinary clinic that cares for newcomer children with special healthcare needs, the only one of its kind in Ontario, Canada. Her research uses community-based participatory research methods to address health discrepancies for migrant children with special healthcare needs through co-developing and evaluating interventions and policies. She holds multiple grants for the Canadian Institute of Health Research, including a prestigious New Investigator grant. She is recognized as a national expert in caring for migrant children in Canada and is the chair of the AAP Chapter 1 Immigrant Child Health Committee, the Newcomer Child Health Special Interest Group, and Caring for Kids New to Canada task force with the Canadian Pediatric Society. Her long-standing relationships with refugee support agencies in Canada and the United States, including shelters, settlement agencies, government institutions, local and federal policymakers, and clinical and community advocates locally and across both countries, help her contribute to advocacy efforts to improve the lives of migrant children in North America. Welcome, Shazeen. I just have a few additional opening slides to go through, and we'll jump into our presentation. Our presenter, Dr. Shulman, does not have any conflicts of interest to disclose at this time. Today's session is being recorded and will be uploaded to our N4 platform. We will share this with you as soon as it becomes available. Should there be technical issues during the presentation, we will inform you with details for an alternate makeup session. Before we begin today's event, I'd like to take a moment to introduce you to the platform we'll be using to enhance your participant experience. Throughout today's session, we invite you to write your questions in the Q&A window. We know that sometimes many of you might have the same question or be interested in particular responses. Today, you have the option of upvoting a question, so please upvote those questions you're interested in hearing the answer to, and we will prioritize those. With that said, let's jump right into today's presentation, and I'm very happy to pass the podium over to Shazeen. Welcome, Dr. Suleman.
Thank you so much. I'm just going to get my slides up for a moment. Well, I am so delighted to be here with all of you, sharing what has been a labor of many individuals that I'm excited to represent today. And as you can see, this is also work that has been shared amongst multiple institutions, as well as community partners, including the N4 network that I'm so happy to be here with today. I am joining you today from Ohlone territory, but as you probably could guess, that I hail originally from what is now the Haldimand Tract, or what is now called Cambridge, Ontario, but is originally on the Haldimand Tract belonging to the Six Nations. And my family came to Canada as refugees. I often share part of my story is how an elder once asked me that if my family had known how Indigenous communities were treated by the government of Canada, would my family have considered this a place of refuge? And it to me really highlights the connection between caring for people who are displaced from their land while being on land where people have been displaced from their ancestral territories. It's intimately connected, and that is what grounds us in the work that we do today. I don't have any financial disclosures, but I would like to share that the work that we're presenting today was funded by a grant from the Innovation Fund via the St. Michael's Hospital Association. And what I hope we can learn today is understanding what are the experiences of healthcare navigation, specifically by youth who have arrived in Canada as refugee claimants, as well as their families, and share opportunities for how we as academics and clinicians can work together with settlement agencies and community partners and families and youth themselves to develop interventions collaboratively, and walk you through an example of this collaboration, which is this toolkit that has been co-designed with a team of outstanding young people. I'm sure everyone here knows and agrees with this, that no child or youth is choosing to be a refugee or an asylum seeker. And specifically, 52% of children make up refugees. Sorry, 52% of refugees are made up by children under the age of 18. I believe this was in 2017. And every year with the Global Trends report, it hovers around the 50% mark. But what is the situation in Canada? I looked at some IRCC data, and what I found was that as of December 31st, 2023, there were 156,000 refugee claims pending in Canada. The US in 1 year gets approximately 700,000 new refugee claims. While that might seem like a big number, if we multiply this to be representative of the US population, that would be the equivalent of 1.5 million claims that are pending. And so it is a similar problem that we face in Canada and the US. And I love this image from the Canadian Council for Refugees that asks someone, which category do you fit into? And the response is, we're running for our lives, which is very true when we're thinking about the very families and clients that we're seeking to support, who fall into this category of a refugee claimant. As many of you know, they are eligible for healthcare coverage through the Interim Federal Health Program, which is a federally managed health insurance program that provides basic medical, so that includes hospital visits, laboratory visits, diagnostic imaging, as well as supplemental care that includes allied healthcare services like speech pathology, occupational therapy, and medical equipment through often a prior approval process. It does also provide prescription coverage that matches provincial drug benefit program. And in terms of compensation, certainly for physicians, it does compensate physicians the same amount as provincial health insurance, but the caveat is that physicians must register to be paid. They're not automatically registered, nor are they legally required to be registered, which means that physicians are able to turn away people who they do not accept IFHP for. I led a study in Canada that actually asked all pediatricians about their knowledge of IFHP, wondering if this is something from the physician end. And when I was told to do this initially, people said, "Oh, don't bother, it's not worth it." But what we found was that only 24% of all pediatricians who cared for clients with with IFHP were actually registered providers. And if we asked them how many of them even knew what the services were that were covered, it was less than 20%. It was about 16%. So this can also show you that there's a dearth of knowledge among the providers that are being cared for, that are caring for patients with IFHP. And what this means is that certainly as a pediatrician, I care fundamentally about what children and youth are able to access along with their families. What this may mean is that youth are not able to get care they're entitled to, potentially making their health outcomes even worse. And they're already experiencing a higher burden of health concerns and disparities. So obviously this meant that we need to intervene and make the system better. But in order to do that, we need to make sure that we have incorporated the unique perspectives of the youth themselves. And up until now, we had not found anything that was really able to do that. So we first started by saying, we now know the data for the healthcare providers, but let's ask a question. What are the actual experiences of young people and their caregivers trying to utilize the healthcare system after arriving in Canada? What we did is we interviewed many different participants across 4 stakeholder groups. This was a qualitative study where we did interviews, and it was rooted in a methodology called participatory action research, which means that the community was guiding this research from start to finish. And I've shared with you some of our community partners. If anyone wants to work further, I will be happy to share my information at the end of the presentation. And what we did is we wanted to speak with youth who ranged in age from 10 to 19. We did have more youth who were over the age of 15, but we intentionally tried to also talk to younger children. We tried to represent a diversity of countries of origin, knowing that there is no monolithic newcomer experience. Some of them had been in Canada for less than 1 year, and half had been in Canada for more, and about 40% needed interpretation, recognizing that if you do not speak in English or French, it is even harder for you to access care. We also spoke with caregivers, and you notice I say intentionally caregivers, understanding that definitions of family are diverse, and for many children and youth who are coming to Canada, often it is not with their immediate nuclear family. We also tried to represent a wide variety of countries of origin, and again, spoke to families who needed interpretation. And what we also spoke to were service providers, many of whom are on this call today are representing agencies from this group today, that these are individuals who you are the first line, you are the front line when you're working with families who've newly arrived. This may be in refugee shelters or settlement agencies. And we tried to speak to people who had both had a shorter amount of time working in the sector and some that had longer amount of time. We also then worked with with healthcare providers. This included physicians and nurses and other allied healthcare providers who had worked with refugee claimants. And we said, tell us about the experience that refugee claimant youth and their families have navigating services in Canada. And I don't think any of these findings will surprise anyone. What we heard is most youth and their caregivers felt they really understood little of the Canadian healthcare experience, including IFHP. And many hadn't been really given any clear explanations, but they relied on the support from their settlement agencies to understand how IFHP work. And here's some quotes. You know, a youth says, I've seen it, the brown paper, but I haven't, I don't know what it is. Another youth said, I think it just sometimes IFHP covers something when you in a health issue. And then a parent says, nobody gave detailed information about IFHP. We were told that when we go somewhere, we use this brown paper as formal ID. And then when we spoke to community service providers said they too had not had much training in terms of how IFHP worked. And they had a very hard time finding registered providers for their clients, as did healthcare providers. So healthcare providers said, I think the biggest barrier is trying to find primary care because the barrier we face is, sorry, we're not accepting IFHP. And they're not required to accept anyone with IFHP, so then we're left with very few options. A community service provider said, I wouldn't say like I have a full understanding of IFHP. My understanding is that it gives access to family physicians and healthcare for refugees. But if you ask me in detail what it covers or everything that is covered, I don't think I would be able to explain all the details of that. What we heard loud and clear, though, was youth and families saying, I want to be able to do this myself. I want to have the tools that I know that I can understand how this healthcare system works so that it's written in a way that makes it easier for me to understand and I can have it available online. One youth said, I think it'll be beneficial to know how to get doctors or how to find hospitals, things like that. This youth said, yeah, I think like making or creating more websites, which like showing us what kind of the IFHP is like doing or what they are giving or helping. And you can see that we've really paraphrased the youth's voices exactly as they are. And I'm sure that none of this is shocking to almost everyone on this call. So we know that IFHP is meant to provide comprehensive healthcare coverage, but in practice, there are many barriers that limit access to care. On one hand, which as a physician, I've been working on with other physician organizations, is really increasing the number of healthcare providers that are registered. But what we also heard is that youth themselves and many providers really didn't understand how IFHP worked, and there's very little navigation support. But youth said, I want to be empowered to do this myself, and I want to have a resource that's accessible and made by youth, written in youth-friendly language. So this is often where research stops. Publish a paper, you share, here's our findings, we need to make this intervention, but this is not participatory research. And what I hope you can hear from this and be inspired is that this is what, as an academic researcher that does community engaged work, I see myself as a contractor to the communities that are most affected by the issues that we're both trying to serve. And just like a contractor, if you're building a house, the contractor doesn't come to you and say, here's the house that you need. The contractor listens to you and says, what is it that you need? How can I use my skills to help you build the house of your dreams? That is exactly what a participatory researcher or a community engaged researcher likes to do. And so this is often how many academic and healthcare providers, we think research works. We think about our question, we do our data collection, we analyze our data, and then we disseminate it. But what I would invite us to think about is how can we shift this to have more of a participatory lens? That's centered is our community partnerships. And I'm really grateful to have such strong partnerships with the Center for Refugee Children and Sojourn House, where together we could identify what these health concerns and questions were. We then design something together. Maybe it's an intervention or a toolkit. Maybe it's about collecting the information to see what we need to do, and then disseminating and mobilizing the findings and continually doing this. This kind of work really has benefits for both community members by being able to harness the talents of academics in a way that benefits them, and also for physicians and for healthcare providers and academics. This is also really important for helping us to develop the outcomes that we're trying to achieve. Multiple studies have looked at the effectiveness of community-based participatory research. Many have found positive outcomes. They show that we actually have better engagement of the community that we're trying to serve. Shocker. There's positive impacts on health behavior, on consequences, on self-efficacy, and social support. And when we've done in these big research trials, it actually shows that families and people who are often left out of studies, which means studies may not be as relevant or generalizable to those populations, by using a participatory research approach, we actually make research more accessible and thus the findings more applicable to all. It also helps us increase how reliable and valid our results are. It helps improve the reach of our work because we all have the same goals, which is trying to make and address the health disparities that all of the communities that we serve are facing. There are some challenges. It does take time, and I know I certainly have experienced this, where you are pressured to produce something quicker in academia. And when working with communities, that I relinquish some of that power to the community. I know that it's going to take time, and some of our academic research ethics boards are really not familiar with these processes. It is important to compensate people for their labor and their time. And so budgets need to be accounted for. There also needs to be adequate budget for translation, for transportation, for food. And it historically has not been as valued in the academic world. I know it's been extremely valued in the communities that actually do this work. But this can limit the involvement of researchers who, again, may have some of those skills to offer. But I think this is changing, and I'm really excited to share with you the results of our participatory research work. So, as you heard, we had heard that youth who said, I really want to be able to navigate healthcare myself. And working with Sojourn House and the Center for Refugee Children, we developed a youth advisory board comprised of 7 young people who themselves had all had experiences as asylum seekers. They represented 4 languages. They ranged in ages from 12 to 19. They included all multiple gender identities, included unaccompanied youth, as well as youth with disabilities. All of the youth were compensated for their time. There was transportation provided, there was food provided. If a family member wanted to come with them, that they felt more comfortable having a parent or a grandparent around, that was also provided in terms of food and transportation and inclusion. Some of the core principles that I have learned is really, it's not about being right. It's about getting it right. And we've gotten it wrong a lot. We mess up a lot. But what this means is that we had to be accountable to both of the community agencies that we served. And I certainly hope they feel that we've been able to do that. I enter with humility that I know that I don't have all the answers, and I should not ever act like I do. It did require a lot of flexibility in terms of when we were meeting, where we were meeting, transparency, honesty, and co-ownership. All of the materials that we have created, they are co-owned by everyone who has been part of that. And you can also, we'll show you that in our toolkit. Like I said, compensation was provided to all of the young people, and we provided language translation and interpretation. When I say co-designing, though, I literally mean co-designing. And here is what an example of, here are the youth literally making with paper and cutouts and Bristol boards a prototype of the tools that they wanted to see. We held meetings like this roughly every 2 months, so about 5 or 6 times. And you can see here that they're pulling together headings and pieces that they wanted to see in the toolkit. And these are the pieces of Bristol board that actually were the first iterations of the tool. We learned so much from these young people. Some of what we learned, the first thing that we learned is, please don't make an app. This really shocked us because we thought when young people were saying, I really want something that's digitally accessible, that meant an app. They said, no, I don't want an app. I want a website that I can go to, that I can click on something, that I can screenshot it. They said, please make sure the font is disability friendly. And this was exactly their wording. I was really impressed where they said, not all fonts are accessible. It might look really nice, but make sure the font is. Make sure the materials, again, can be downloaded. Make sure they can be easily accessed with a QR code. Make sure that they can be screenshot and saved on a phone so that if they need to look at something, they can have it on their phone as a picture. And as we were making this toolkit, the headings were actually questions as opposed to a statement. And I'll show you some of this as we went through. These are all things that sound really small, but I can assure you that if this was a team of pediatricians who are trying to create this intervention, our intervention would have looked very different. And this highlights the importance of working with youth directly to be able to make something that's meaningful for them. I am so excited now to introduce you to this toolkit because it was meant to help youth and their families navigate the Ontario healthcare system. If you look at the cover page, the authors who are listed are the youth advisors. They are the primary authors, and that is important to highlight their contributions and their work. And what they said specifically is that this toolkit is actually meant for anyone. It's designed for youth who have newly come to Canada and are living in Ontario. It can be disseminated to them, but it can also be used by anyone who is newly arrived in Canada and living in Ontario, as well as people working with families. So it can be used by settlement workers. It can be used by healthcare workers. What we want in the table of contents, you can click on the section you want to read more about, but we also have 2 tools that the youth developed that are meant to be printed or saved or screenshotted that they can use with you. In the toolkit, all of the headings are questions. And so here's an example of something that as a provider, I wouldn't have thought was important to cover. So the youth specifically said, I want you to tell me that dental braces are not covered. This is a big question that we have. I want to ask about other forms of therapy. I want to know about, specifically dental was one that came up, dental and mental health therapy. And it shows the importance and value of working together with youth who are affected by what you are trying to address. So in this case, we're trying to address access to healthcare, and it's important that we make sure we're using with youth to write things in a youth voice. And we also put these little exclamation marks that said, well, what do I do if I don't have something that's covered? How can I get through this? I haven't gone in detail through the toolkit, but I'm happy to walk you through it as well. What we cover are what is IFHP? What are the documents that you need to prepare? What are the services that are covered, along with examples of what those services are not, or what services are not covered. We also talk about how you can check what your coverage status is and what to do before you go for a healthcare visit to make sure that you are not charged or turned away for care. And one way that we can help people do that is we created 2 tools that providers, youth, families can print out ahead of time and bring with them to any healthcare service. On it says, attention healthcare provider, I speak blank, so that this can be filled in right from the get-go, that the healthcare provider is alerted to the fact that this family may need an interpreter to be communicated with. It also states very clearly, I have medical insurance under the interim federal health insurance program, and we have put a space in to put the UCI number, which is what the providers need in order to do billing. And then it says, please inform me if you accept IFHP as insurance before you register me for services. This is important because we have heard from many families that as they have gone for services, they have not been informed, and then they get a bill later, which makes it not only difficult to get overturned, but it also disrupts trust. It delays care. And we want to try and mitigate this as much as possible while we work to make sure that in my dream world, every physician and every healthcare provider would be required to accept IFHP. And if the physicians need more information, we've provided, or healthcare providers, we say, please call this number so that you can find out more. We've also made this as a wallet card, kind of similar to an OHIP card. So again, someone can print this out, or healthcare and settlement agencies, feel free to print out multiple copies of this and prepare this with each of your families, where you can encourage them that whenever they visit a provider to put this in front of them and say, I speak this language, this is my coverage, please inform me if you accept this insurance before you register for me for services. And if you do not, in the toolkit, we have a step-by-step instruction for what to do if someone says they do not accept IFHP. We also have an instruction manual, an instruction section for what to do if your provider, if you're not sure if you're registered. And there are instructions for individuals themselves to be able to check their own coverage status, as well as for providers. In addition to IFHP, we have a section on the provincial health insurance process. And this is because we found that one other barrier in care was when individuals shifted from being covered with IFHP to being covered by provincial health insurance. There are some differences in coverage, which are not always clear. And there's a different process in terms of maintaining your coverage with OHIP, for example, in Ontario, as many of you know. And in that same toolkit, because we were working with youth from Ontario, the youth had a lot of questions around what happens when I don't have IFHP anymore and my claim has been approved and now I have this thing called OHIP. What did our youth say? These are some quotes that the youth actually said themselves. I love that I got to see and be a part of the behind the scenes of making a toolkit. It was interesting and fun. More professionals working with youth will make their work trusted among youth, knowing something was made by people who are around their age group, and it will also bring in unique ideas. Another youth said, it was a really good experience, and especially helping people makes me happy. And I like that it will be very helpful for the newcomers. And I just wanted to pause because part of engaging youth in work is also ensuring that there are safe ways for them to participate. And so instead of participating in this webinar today, which almost all our youth advisors said no, I said, well, how is there another way that I can elevate your voice that feels safe for you? And quotes, videos, voice are another way that you can do that. But I do want to highlight that one of the youth here had come as an unaccompanied person who was also caring for their sibling who had a disability. And so it was a youth who was placed in a caregiving role. And this other youth at one point had said that this was the most meaningful experience for them since arriving in Canada, because they felt so engaged and that they were giving back. I think the value of feeling like you're contributing to something greater is often something that is not really well appreciated when we do participatory work. And especially for young people who are going through migration, being part of something that they know that they've contributed to, that they can feel proud about, that they can see the results of their labor are appreciated by others in their new host country is so important in contributing to resilience and healthy resettlement. And so it's just another added benefit of doing this kind of work. So what are our next steps? I invite all of you to see the toolkit. You can see the link on my background right now. As you can see right now, it is in English because that was the language we first made it in. We are working towards digitizing it. So that means it's more clickable and people can click through it, as well as translation in multiple languages. Right now it was made for Ontario, and we would love to adapt it for other provinces, including Youth Voices. We are looking to work with other agencies as well as applying for grants to have more of the capacity to do this. And again, adapt it specifically to youth who are newly arrived and living in different provinces, recognizing that their experiences may also be different. And most importantly, we do want to measure the impact. We would love to know how this has helped or not helped you or your organization. We encourage you to spread this far and wide. Anyone can use it everywhere. The more people that can use it, the better. We have had all the information verified by IFHP and IRCC, so you can be assured that that information is as up to date as possible, but certainly as new things change or if you find errors or discrepancies, please do let us know. So I want to make sure we have adequate time for questions. And so in summary, I think much of this is familiar to many people here, that the healthcare system is difficult to navigate, and asylum seekers especially have limited support, and asylum seeking youth said, I'm not able to get the care that I'm entitled to and I need. But I hope this toolkit is an example of how when we work together with young people, combining healthcare, academia, community support, all together, we can lead to the development of a meaningful solution. And like I said, this toolkit is meant to be used by anyone trying to navigate IFHP and the Ontario healthcare system. We encourage you to use it. We encourage settlement providers to use it. Please disseminate and use it widely and let us know what other things we can do. And so I'm going to pause because I think now we have a lot of time for questions, which are great. But I do want to thank many of the partners who have made this work possible. You can email me. This is my Stanford email. You can also email me at my UToronto email. And I really want to especially thank the youth advisors and the authors of the toolkit who are the main architects of this. And we are so grateful for their knowledge and brilliance. So thank you so much for your attention. I'm going to stop sharing my screen and turn it over to Colleen for some questions.
Wonderful. Thank you so much, Shazeen. Wonderful to see the youth voice in action and the tools that have come together from those discussions and collaborations and the partners that have come into play. And we do have some time for questions, which is great, that audience participation. So we'll jump right into those. And here we go. So, wondering if you know of any research or project looking into healthcare needs of undocumented refugees who are not yet claimants without IFHPs. Where do they go for healthcare issues?
This is such a great question. And as I said, this was specifically looking at navigating IFHP. But one of the shortcomings, I believe, of our system in Canada is that for individuals who are undocumented, particularly children, there are very little resources. Currently, what that means is going to community health centers to see if they can provide access to care or free clinics. That being said, I know, and I am working with a number of individuals, and there are some coalitions that are working to advocate for healthcare for the uninsured. During the pandemic, we saw that this was possible. The government of Ontario did allow services for covered services for uninsured people, and we saw how helpful that was. And so I would encourage people here to say, let's see if what we can do to bring that back. That is so important. I will also share that as a provider in California right now, California allows anyone who is eligible for Medicaid, including undocumented folks, anyone who meets their eligibility criteria is able to get full scope Medicaid, which is their equivalent of public health insurance, regardless of immigration status. So it is easier for me here to care for a child that is undocumented because they can have access to full scope public insurance than it was for me in Ontario. And I think this is a really good opportunity to say, if the United States can do it and certain states in the United States can do it, then what can we do here in Canada? I wish I had a better answer for you, but I want you to know that this is certainly something that many of us are advocating passionately for, and we need as many voices as we can get. I'm happy to share some of those connections afterwards.
Thank you so much. Our next question is, does IFHP cover virtual care services? So such as video visits, remote monitoring, patient portals, both for the patient access and provider billing for healthcare services. Are you aware of
It's
anything?
a great question. IFHP will cover whatever your province's whatever is covered by your province's health plan. So certainly in Ontario, virtual visits are covered by IFHP because they are also covered by OHIP, but it will differ a little bit by province to province.
Fantastic. Thank you for that information. And as we mentioned earlier in the presentation, if there's anything that you'd like to reach out to Dr. Suleman after the presentation, we're happy to have her answer any additional questions. Um, do we know why providers can refuse IFHP? Um, and they're just stating that they don't believe that they can refuse OHIP or other provincial health coverage.
That is a great question. And I am not a legal scholar, but I'm going to share with you my understanding. That is because of a law that essentially states that if somebody has OHIP or provincial health insurance, the physician is required to accept that. And that does not include federal health programs. So I think there's a really good opportunity for advocacy here at a provincial level, because this is provincially mediated, that if someone has IFHP, it's a similarly publicly funded program, that healthcare providers should be required to accept it. And again, I think there's a lot of ways for advocacy here, but that is the reason why OHIP cannot be denied.
Thank you for that extra information. Um, does IFHP cover pregnancy services for teens or refugee women in general? Also wondering about sexual health clinic services. And thanking you for your
Absolutely.
time.
IFHP covers all medical services, and that includes for all ages. If someone holds IFHP and that is valid, all pregnancy related services, including prenatal care, delivery, and postnatal care, will absolutely be covered, as well as sexual health. That includes, for example, IUDs are covered under IFHP, birth control is covered under IFHP, all STI testing, as well as treatment of sexually transmitted infections are all covered under IFHP.
Fantastic. Thank you very much to our audience for keeping these questions coming. It's great to have this dialogue and this opportunity to connect with Shazeen. Is there any work underway to advocate for the care of the uninsured? If we could at least insure children for coverage, as you said, they're just stating no child chooses to be an asylum seeker, so they're just stating that as a obvious. Yeah.
Absolutely. There are a number of individuals and community-led coalitions that are advocating for this. Some that come to mind that I also am part of are the Healthcare Network for Uninsured, the Healthcare for All Network, and the Migrants' Right Network are absolutely doing advocacy around this, and we need more voices and support.
Fantastic. Thank you. We have a question. Do you know if New Brunswick has anything similar or perhaps working towards a toolkit? Very impressed with your work. Yeah.
I don't believe there's anything similar, but I would love to work with folks in New Brunswick if that's something that we can adapt, because like we said, this is something that can be absolutely adapted and provided across the province, but we want to make sure it really centers on the youth in those communities.
Absolutely. Okay. And it sounds like I have some volume issues, so I'm hoping that everyone can still hear me. They're just asking, will we have access to your presentation, Suzean, following? And obviously, yes, we'll the N4 team will make sure that that's available, and the toolkit as well is available on the N4 website. So if you are interested in learning more, please go and check that out. We're very excited to share more details and have an opportunity to collaborate. Um, During your research, did you have the chance to work with a French-speaking group? Any difference in navigating the system from that particular group?
As mentioned, we intentionally tried to work with people who spoke multiple languages, including French, Spanish, Arabic, Dari, anyone who didn't speak English, which is predominantly what is used. And certainly language barriers are an issue. That is exactly why we made those tools that put right at the top, I speak X, please use an interpreter to speak with me, that the patient or the individual themselves can put right in front of the clerk when they're registering, say, this is the language I speak. I'm asking you to use an interpreter to speak with me. Now, interpretation is a very interesting conversation as well. Not all provinces have provincially covered interpretation, while others do. And certainly as the Canadian Pediatric Society and the Caring for Kids New to Canada Task Force member, we have put out a position statement saying access to interpretation is essential.
Mm-hmm.
We encourage provinces to consider making a provincially covered interpreter services, because in many provinces, including Ontario, it depends on the individual institution to be able to use an interpreter and pay for that out of pocket. Versus in some provinces like British Columbia, there is a provincially available telephone interpretation system. There's a lot of data that shows there's actually equivocal responses between telephone and in-person. Some data says in-person is better. Some data says there's no difference. Some data says video is better. But certainly we know that interpretation at all is better than no interpretation. So again, there's another opportunity for advocacy. And we also hope that in utilizing this toolkit and making that issue very known to the providers they're seeing by putting front and center, this is the language I speak, that will also help advocate for better access to interpretation. Because similarly, if a healthcare agency says, well, I don't provide that interpretation, then you can go elsewhere where that interpretation is provided. And I think I see another question in the chat.
Absolutely. There's sort of a scenario that they wanted you to sort of think about and give some insight into. So obviously this individual is just commenting on how you can go to the emergency room and show your documents. Everything seems like it's working well, and then they go home and receive a bill for the services. So they're charged for these services, and they're just wondering what can they do in these situations where they've run into it. And I know we've heard similar situations before. So what would you recommend or suggest for someone who's come across this?
So I'm so glad you asked this question, because this is also experiences that I've seen with some of the clients that I serve. So number one, this is also why we've made that tool, that letter that can go along with the IFHP paperwork that says very clearly, please inform me if you accept IFHP before registering me for services.
Right.
That being said, every hospital is registered with IFHP. However, it doesn't mean that the unit clerk or the person who is actually doing the billing in that moment knows how IFHP works. If you have a client who has IFHP that gets a bill, number one, do not pay it out of pocket. If you pay it out of pocket, you will not get that money back. The first thing that they should do is go to the accounts department, the accounts receivable department at the hospital, with their valid documentation and say, I received this bill. I have coverage through the Interim Federal Health Program. Please submit my services through the Interim Federal Health Program. And this may be something that as advocates or as settlement providers and as healthcare providers, we can also do to help advocate for families. We can go along with them. And often this gets reversed. When the billings department sees this, they say, oh, whoops, it was never, the IFHP document was not submitted when that bill was processed, because the unit clerk or the person doing the billing only saw a spot for provincial health number, left it blank, and then that automatically goes to a bill.
Right.
However, remember I said that IFHP services mirror what is covered by your provincial health services. In many provinces, ambulance visits for non-emergent reasons are not covered by OHIP, and even families or provincial health services. So even families with provincial health insurance, if they call an ambulance for something non-emergent, may be faced with an ambulance bill. In that case, if you believe something is important, you can also call IFHP directly. I have found them to be incredibly helpful as a team. They really do want what's best for families, and they are not always aware of how their services are being denied in the healthcare institutions. So I would actually call IFHP and see if there's a way that they can actually let you know if they need to have a special authorization form or documentation to see if that can be covered. But certainly for medical care in an emergency department, that is absolutely covered by IFHP. But what this highlights is how much misunderstanding exists around IFHP that still leads to so many barriers for care. And we are hoping that this is just one piece that can contribute to kind of combating that.
Fantastic. Thank you so much. I'm sure the individual is very appreciative of having that detailed response. I do have a couple of additional questions that have come in. So, with the toolkit being related to Ontario, where do you see next steps? Are there plans for expanding this to relate to for other provinces? And obviously, there's some interest in New Brunswick, so I think you'll be headed there next. Do you see it expanding, and where do you see this going?
Absolutely. So we started in Ontario because that's where I was practicing before I moved south of the border. And those were the patients that we were seeing. But we would love this to be something that's available across the country, adapted to every single province. That does require partnerships. That does require working with young people in each of those provinces to make sure that toolkit is catered to their needs. And that requires funding to be able to support the labor for all that work. So those are the next steps we're headed in. But certainly if there are people that are interested in partnering and doing this work together, please reach out to me or the N4 network, because I know that we're all committed to making sure that this is as widely accessible as possible.
Fantastic. Thank you. And this is sort of related. So, with changes always happening as they do in the healthcare system, will this toolkit be updates be reflected, and how often will those take place in the future?
That is a great question. I think certainly at least yearly, we would aim for an update, recognizing that sometimes changes happen. Right now, the changes, we took a lot of time. We took almost 2 years to put this toolkit in. And there was one set of updates that happened on April 1st that we were able to incorporate. That being said, if there are major changes, and certainly we have seen major changes when there have been different administrations and different political priorities. If that is the case, we would certainly do our best to update that in collaboration with our wonderful partner, the N4 network.
Well, I'm getting all kinds of thank you very much for your support of N4, Shazeen. We so enjoy working with you, and I have a couple comments popping up in our Q&A saying they would love to partner with you as well.
Yay!
So this is fantastic, and we'll look forward to making those connections for you. I'm just taking a quick look at the time, so I think what I'll do is I'll just wrap up. Oh, if there's any other quick questions we can jump to, let me just see. Those are all fairly detailed. So any questions that we didn't get to today, we'll absolutely make sure that Shazeen has answers for you, and we'll share with the audience. What I'll do is I'll just run our exit slides just to promote some upcoming events, and then I'll make sure that I jump back to you, Shazeen, for last words before we sign off. So thank you so much, and bear with me for a moment while I pop up our closing slides. Fantastic. Oh, sorry, just a small technical issue, but they should be up and running in mere moments. Oh, perfect. Okay, excellent. So just some promotions of some upcoming events that will be happening at N4. And obviously a big thank you to Shazeen for taking time to participate in today's discussion. And as always, many thanks to our audience for taking time to attend today and engage with us. You are welcome to attend some of our future events, which we have listed here on the screen. If you missed any part of today's presentation, or you'd like to watch the session again, we'll post the recording on the N4 platform. And we want to continue this discussion. So I'm happy to take any of those questions offline for Shazeen. And they'll be placed in our moderated discussion forum called Meeting Place. We have also curated several resources related to today's presentation. The toolkit, definitely check that out. Make sure that you have an opportunity to become a member of N4 Obviously, those resources are one of the benefits. Following today's session, we will invite you to complete a survey, and this is important so that we can have feedback, and those responses really do help us um, plan for future events. So please do follow the link and complete the survey. Today, we are pleased that our webinar is accredited by the Royal College and the Canadian Psychological Association, CPA. And Royal College members earn 1 credit, CPA members earn 1 credit. So thank you very much for joining us if you have attended. The ITP and IEN pathway was published in December, and we are very proud to highlight these products, which are part of N4's IHP Resource Hub. So if you haven't already, please be sure to check it out. We're now focusing communication strategy on IENs and looking to connect with those groups. Check out our N4 mobile app if you haven't, and you can access that on Apple or Android. We do have a QR code, and thank you again. We do hope that you enjoyed spending time with us today, and I'll hand it back to Shazeen for any last words before we sign off.
Just that I hope I want to make it so clear that even though I'm the one presenting for you today, I'm really just the mouthpiece for a team that has done this work. And this is really the value of partnership. So I love working with others. If there are ways that we can all work together, there's an expression in my own culture that 5 fingers make a fist. And so it really is that we're stronger together, and there's so much advocacy that needs to be done. Thank you all so much for attending and for the amazing work that you do to make our families' journeys a little bit easier.
Thank you, Shazeen. Wonderful words to end on, and we look forward to future collaborations. Everyone, wishing you a lovely rest of your morning, rest of your afternoon, and please join us at a future N4 event. Stay safe and well. Have a lovely day. Bye.